all with the webinar on landmark. Welcome all my Indian and this webinar series by MedIndia Hospitals and Academy, Chennai, affiliated to the Tamil Nadu Dr. MGR Medical University, and academic sponsors being Microlab, the Knowledge Academy. The first series was held on 11th July, and the faculty were Shivakumar Sareen, Dr. Nageshwar Reddy, Dr. Vinita Aguja, and it attracted over 3,000 delegates from all over the world. The second series was held on 29th August. Every month we thought of having a webinar. That was on luminal disorders. The speakers were Professor Mahesh Goenka, Professor Govind Makaria, and moderated Dr. Ajay Kumar, Mohan Prasad, SP Misra was the commenter. And it went on very well, attended over 1,000 people from all over the world. Third series was on pancreas. The speakers were
having a webinar.
Anything urgent? Amit Medho and Professor Pramod Garg, and moderated by Dr. Ramesh Ruproy and Matthew Philippe. And commenter was...
We'll treat it and then discharge. We won't discharge.
Now the fourth series, now we are here today. Now we know we are enjoying that one of our faculty, three of our faculty who worked for hepatitis C, Professor Alter, Houghton, and Rice, their work has been recognized with the Nobel Prize. On this occasion, we are going to have a topic on hepatitis C, and the other topic related to liver is non-alcoholic steatohepatitis, NAFLD, non-alcoholic fatty liver disease. We have two eminent speakers who will be introduced by our moderators, Professor Anil Arora and Professor Akash Shukla. I have great pleasure in introducing my moderators, Professor L. Venkatakrishnan, who has been our student, one of the few gastroenterologists, I would say that, who is really dedicated, not few, one among the gastroenterologists who are dedicated to the passion of working in gastroenterology. He is a professor and head, Department of Gastroenterology, PSC Medical College at Coimbatore. He had his fellowship training in several places in advanced endoscopy in Belgium, and he had a liver transplantation training in France. Now he's running a liver transplant course, and he's running a DM course also in gastroenterology. I welcome you, Dr. L. Venkatakrishnan.
Thank you, sir.
We have another very young, dynamic, Dr. Ugal Das. He is the Secretary of Tamil Nadu Indian Society of Gastroenterology. He is doing a wonderful job, and he is doing a dedicated service to Tamil Nadu ISG. He is a consultant gastroenterologist, Apollo Hospital, Chennai. And after that I welcome you, Dr. Ugal Das, for this unique webinar on landmark publications in gastroenterology.
Thank you, sir.
We have Professor S.P. Singh. I know him since several decades. He's one of the senior most gastroenterologists of our country, representing eastern part of India. He has been the president of Indian Society of Gastroenterology and the president of INSL, Indian National Association for Study of Liver Diseases, and Asia Pacific Liver Disease Society also. He is a special interest in NAFLD, and he's got a keen interest in, apart from the NAFLD, he does a lot of work in luminal gastroenterology too, and is a good endoscopist too. Professor S.P. Singh, it's my great pleasure to welcome you.
Thank you.
Professor S.P. Singh. Now with this, we will move on to what are our forthcoming series. The fifth series will be on 21st November, and this will be advanced endoscopy imaging by Professor Noria Yudo from Osaka Cancer University, Japan. And we have Professor John Salzman from Brigham and Women Hospital, USA, who is going to talk on non-varicose UGA bleed. This is going to be landmark publication. And we have very eminent people who are going to moderate and going to comment. Professor Nalini Guda, Dr. Vivek Saraswat from India, and Dr. Vivek Kaul from USA. And the sixth series will be on upper GA and colon disease. And Dr. Pritesh Sharma from University of Kansas Hospital, USA, is going to talk on GERD and the Barrett's esophagus. The seventh series on biliary, that will be on 23rd January. And biliary disease, tone and stricture, by one of the most eminent person who is working on the biliary disease, Professor Todd Barron from University of North Carolina, USA. And myself will be talking on biliary endotherapy. My mentor, a great person in gastroenterology, Professor Richard Kojarak, will be moderating entire session from Virginia Mason Medical Center, USA. And have another very enthusiastic gastroenterologist, Dr. Murthy Badiga from USA, will be the commenter. The last series, landmark webinar series on Saturday, 20th February, the third space endoscopy by Professor Norio Fukami from Mayo Clinic, Arizona, USA, an interventional US from another eminent gastroenterologist, Dr. Kenneth Binmoller, California Pacific Medical Center, USA. So I welcome you all to this webinar. This is not going to be the end. This is the beginning, because the proceedings of the 8 webinar series will be published as a book, and that will be given to all the gastroenterologists. And every webinar is going to be so far accredited with the Tamil Nadu Medical Council with 1 to 1.5 the credit hours, and we issue a certificate, e-certificate. Whoever wants this will issue the e-certificate, and they just have to email to us. We will send to the registered delegates the e-certificate. This has not have been possible without the efforts from my in-house team, Dr. Gokul, Dr. Satyamurthy, Dr. Raja Yogesh, Dr. Prasad, and Tringyana Sambandam, and of course the academy partners, Microlab. And finally, before we take off, 2 simple words, thank you, to tell you that from MedIndia Hospital. Okay, now I hand over the mic to Professor L. Venkatakrishnan, who will introduce Professor Anil Arora, and he will introduce the topic hepatitis C. And now I hand over the mic to Dr. L. Venkatakrishnan.
Good evening, sir. Good evening to all. I'm very thankful to you for having given me the opportunity to participate in this wonderful webinar series, which you have taken. It is a great initiative. I deem it a great honor to introduce Professor Anil Arora, whose masterly postgraduate yearly annual program in Gangaram is eagerly awaited and always attended by all of us. Dr. Anil Arora is a highly qualified gastroenterologist. He completed all his academic studies of MBBS, DNB Medicine, MD of Internal Medicine, DM Gastro from the prestigious All India Institute of Medical Sciences, Delhi. He subsequently obtained his liver transplant fellowship from Queen Elizabeth Hospital, Birmingham in 1999, and was awarded the fellowship of Royal College of Physicians of Edinburgh in 2004. He also obtained his fellowship from Royal College of London in 2014. At present, he is the director of the Institute of Liver, Gastroenterology and Pancreabiliary Sciences at Sir Gangaram Hospital, which is one of the premier academic institutions of the country. He provides a very high standard of clinical care to the patients, and has been regularly writing the scientific articles in national and international journals, leading to over 150 publications in index medical journals, and he has authored a number of book chapters. He's a very skilled endoscopist, regularly performing interventional endoscopy and all types of therapeutic endoscopy procedures. He has a great interest in study of viral hepatitis and is well known for his expertise in treating chronic hepatitis B and C infection, stem cell therapy in liver disease, and liver transplantation. He keeps himself updated with the latest trends in medicine with an inquiring and inquisitive mind. Presently, he is also head of the liver transplant team and coordinates all activities, academic activities, Institute of Gastroenterology in Gangaram Hospital. He is going to speak on 10 landmark publications of hepatitis C. Hepatitis C has been very, very unique this year because the founders have been given Nobel Prize. And the best thing of hepatitis C is within 13 years, hepatitis C has been a translational research success because we were able to identify 30 years back, and probably now we are almost reaching the cure of hepatitis C. As a great pleasure, I hand over the mic to Dr. Professor Anil Arora to start his talk.
Thank you, Dr. Venkat Krishnan, and for a very elaborate introduction. I am extremely thankful to my friend, guide, mentor, and philosopher, Professor Chandrasekhar, who had been a dear friend for almost 30 years now. The topic which has been given to me is the landmark publications in field of hepatitis C. The reason we have chosen this topic today, and that is what has, I think, prompted Dr. Chandrasekhar, is because, as everybody has already mentioned, that only recently we had the discovery of hepatitis C virus, by three people getting the coveted Nobel Prize in hepatitis C discovery. So what I am going to talk today is just not the monopoly and the regular routine of the papers, but I'm just going to take you through the journey of how did these people think of diagnosing, discovering, and getting it from the bench to bedside, the various types of hepatitis viruses, including hepatitis C. We know that hepatitis B was discovered way back in 1965 by Professor Bloomberg. Then hepatitis A was discovered 10 years later by Dr. Feinstein. But still, in any surgical unit requiring blood transfusion, there used to be a lot of patients of post-transfusion hepatitis or PTH. All those gastroenterologists, including those of our age who would have done their DM and MD in the eras of 60s, 70s, and 90s, would be pretty well aware of the fact that post-transfusion hepatitis was an important clinical entity which was requiring day-to-day attention. Thanks to this gentleman, which I'm introducing as a gentleman named H. Surprisingly, Harvey Alter, the first recipient of the Nobel Prize for hepatitis C discovery, wrote a pre-posthumous obituary for this man. So giving all respect to this man called H, he was just climbing, he was on a pleasure trip with his wife and had went on a voyage. While climbing a steep hill, he developed chest pain and almost had a cardiac arrest. Luckily, his wife was having good knowledge of the CPR, so she just revived him and immediately shifted him to NIH, that is Bethesda, National Institute of Health, Bethesda, US, where there was a very competent first-class team of cardiac surgeons who immediately performed cardiac surgery on him. And I'm sure most of the people at our age do realize that those who were undergoing CABG in those days would require a lot of blood. And this gentleman had received 17 units of blood transfusion. So this gentleman, who has been repeatedly referred to as H because his name started with H, 6 weeks later in NIH itself, he had raised liver enzymes. So luckily, the hepatologist in that unit was Professor Harvey Alter, who again diagnosed him to be having post-transfusion hepatitis. Taking a clue from it, and since NIH was one of the leading centers of hepatology research, Dr. Harvey thought that why not do some research on this gentleman, take his blood and see whether he has an infectious material. So what Professor Harvey Alter did was that he took the blood of this gentleman called gentleman H on 2 occasions. See, this is the retrospective plotting of the antibody level in the blood in the yellow marks. And in the red marks, you have the ALT levels. So within 6 weeks of onset of jaundice, when his enzymes were not very well elevated, 500 ml of the blood was taken from this gentleman at this point of time. And when Mr. H's LFT became normal, another sample was collected. So there were 2 samples which were collected from Mr. H. The first sample had 500 ml of apheresis. And at this point of time, this was called point A, when the ALT was still rising. And when this blood was transfused into chimpanzees, if you see the right graph over here, chimpanzees did get acute viral hepatitis. When at point B, Mr. H's blood was taken at a time when the ALT was settling, so his RNA in the blood possibly was low, so the chimpanzees did not get any infection. So they concluded that after 6 to 8 weeks of occurrence of some viral-like agent, you tend to develop antibodies which will neutralize this antigen, and hence, if you take a non-infectious sample, that means a sample in which the virus has been neutralized by the antibodies, you may not develop infection in the chimpanzees. So in the second B sample, there was ALT which had peaked. The infection was not, the sample was not infectious in the chimpanzees. So they believed that by that time, there were enough antibodies which have come into the blood. You see, this is the antibody level which was retrospectively plotted. So once you have enough antibodies, they will neutralize the antigen, and hence chimpanzees will not get an infectious material. So for the first time, this gentleman was designated the H strain. Whatever blood he had, he was designated to have H strain of non-A, non-B hepatitis. So this was the first landmark publication for which Professor Alter has been awarded the Nobel Prize. This was published way back in 1978 on 4th March. And the pathologist in this was Hans Popper. All of us are pretty familiar to him. This is gentleman, Professor R.V. Alter. So he demonstrated for the first time that if you take the blood from the infected patients with post-transfusion hepatitis, he took blood from 5 patients, 4 of them with acute hepatitis, and 1 patient had a repeated rise in ALT because there was past history of transfusion. So you have a total of 5 patients in which the blood was taken from the acute or chronic post-transfusion hepatitis patients. So they were inoculated into the chimpanzees, and chimpanzees were looked for enzyme elevation, plasmapheresis, liver biopsies at repeated interval. When all these chimpanzees were totally isolated, there was no orophycal contamination, and they were totally housed separately for a period of 2 years. So these were the 5 patients who had raised enzymes. So they had raised bilirubin. The incubation typical period was anything between between A and B, and then they, after transfusion, all the chimpanzees developed acute hepatitis like picture, and the inoculum was anywhere from 3 to 75 ml. So 3 to 75 ml of the blood from the 5 patients developed jaundice in all the patients, and none of these chimpanzees developed hepatitis A or B, and all animals, all chimpanzees had a complete biological, molecular, and histological recovery. So their conclusion was, for the first time it was shown that you have an agent which causes a similar disease in chimpanzees. It is a transmissible agent which can be picked up both from the acute and the chronic state of post-transfusion hepatitis. It can persist in the blood for a long period of time, and that was a clue that hepatitis non-A, non-B could be chronicity. And the histology in the chimpanzees was almost akin to what you see in typical type A or type B viral hepatitis. So that was the beginning of discovery of non-A, non-B hepatitis. Subsequently, this blood of this gentleman was stored, and this gentleman repeatedly underwent further investigation with ALT and repeated liver biopsies. Mr. H, until he died 32 years later of unrelated disease, had undergone 4 liver biopsies. So his liver biopsy, coupled with 38 more liver biopsies from other patients with post-transfusion hepatitis, were subsequently analyzed by Dr. Hans Popper, and they came up with this conclusion that all patients with non-A, non-B hepatitis can have presentation with cirrhosis to the tune of 10% at presentation. Majority had mild hepatitis, and 13% of those with chronic active hepatitis, if they were followed up with liver biopsy, 1/3 will remain stable, 1/3 will become progressive disease, another 1/3 will have deterioration of the disease. So out of the 39 patients, ultimately 8 patients, that is 20% patients, had liver-related deaths within a period of 10 years. So this was the first study, even prior to the discovery of hepatitis C, which gave us an excellent natural history of the disease, which we know today also that 20% of all patients infected with hepatitis C ultimately develop chronic hepatitis and die of cirrhosis of the liver. 10 years later, there was another publication from Feinstein's group, which showed that if you take this infected specimen from the chimpanzees and from the human beings, and if you treat them with chloroform, then this infection was no more infectious. This inoculum was no more infectious to chimpanzees. So this was first proof that non-A, non-B hepatitis is an enveloped agent. We didn't know at that time it was a virus or bacteria or anything or spirochete. We only know it is an agent. So this was a proof that we had a lipid soluble agent which was present at that time. Then there was an excellent publication from Dr. Hufnagel's group in 1986, even before hepatitis C was diagnosed. 10 patients of chronic non-A, non-B hepatitis were treated with recombinant human alpha interferon for a period of 12 months. And look at the results. 8 of the 10 patients had improvement in aminotransferases, and up to 1/3 of the patient had marked improvement in histopathology. So even with small doses of interferon up to the tune of 1 million international units per week, you had 30% cure of non-A, non-B hepatitis. So the treatment of hepatitis, so-called hepatitis C at that time, had started even prior to the discovery of this virus. But I think the biggest discoverer was this gentleman called Michael Houghton, who was working in Emerville in a Kirion corporation. So this gentleman's work was so good and so impressive that I like to spend some time to explain to you how this gentleman discovered the agent of viral hepatitis, which was non-A, non-B. He isolated a complementary DNA clone which was derived from a blood-borne non-A, non-B viral hepatitis genome. That is the reason he has been awarded the Nobel Prize. Let me tell you, what did he do? So what he did was he picked up the infectious material containing high infectious titer of the so-called virus, and they extracted after excellent and extensive ultracentrifugation, and they got their nucleic acid extracted in the form of pellets. Since at that time it was not known whether the virus is RNA or a DNA virus, so the whole genome was denatured, and then its complementary DNA was synthesized using a random primer of reverse transcriptase. So they created a complementary DNA library which consisted primarily of infectious material which was produced in the chimpanzees. And these infectious clones containing cDNA then were transfected into the bacteriophage called gamma GT11. And then as the bacteriophage had incorporated that incoming complementary DNA, they would express some polypeptides. And then Michael Houghton picked up the serum from the infected individuals who were suffering from chronic hepatitis non-A, non-B. And imagine after screening 10⁶, that is 1 million recombinant bacteriophage, led to the discovery of only one positive complementary DNA clone called 511 and a bigger clone called clone 81, which reacted with the patient who was positive for non-A, non-B. So you collect a material which is totally unknown from chimpanzees, you create a complementary DNA library in the bacteriophages and look for the polypeptide products and try to match them with the infected sera from the individuals with chronic hepatitis B. And after screening for 1 lakh or 1 million clones, only one clone was reactive against hepatitis C patient who were ultimately diagnosed to have non-A, non-B because of hepatitis C. So they tried to label this probe called C81 probe or C511 probe. And then subsequently, they also showed that this type of probe will not hybridize even with the human DNA nor with the chimpanzee's DNA. So this was the first proof that the HCV virus was not DNA. That means it was neither hybridizing with the chimpanzee's DNA nor with the human DNA. So this was the first concept which they picked up, that this virus is an RNA virus. So because there was no hybridization which was occurring with the human or the chimpanzee's DNA. Then subsequently, they also looked at the total RNA extracted from the chronic non-A, non-B infected chimpanzees, and they did the hybridization with the clone which they had extracted from the infected chimpanzees. And look at the way they could show it up. Only in the infected chimpanzee's liver, they were able to hybridize this complementary DNA with the use of the probe which they had picked up from the infected individual. Moreover, they also did a good experiment that even before and after, if you try to denature the DNA, the hybridization was still occurring. But if you try to denature the RNA, the hybridization band will disappear. So this was the first proof of the concept that you are dealing with a RNA virus, which was picked up by these gentlemen. So RNA virus was subsequently found to have only single-stranded, because once you denature the RNA and double-stranded RNA and DNA, it will split into two fragments. And if you look at the hybridization, only one of the strain was getting hybridized. So this was another proof that you were talking of a single-stranded RNA. So gradually and slowly, you are trying to decipher the various components of the virus as to be single-stranded RNA, enveloped virus containing so many nucleotides. This could be judged by the thickness of this band. The higher the thickness, more the nucleoside. So this middle range would indicate a range of about 10,000 nucleotides. So this gentleman said that you are dealing with a single-stranded agent, you are dealing with an RNA agent, you are dealing with a enveloped agent, which was made up of about 10,000 nucleotides. In addition, they also clearly showed that they had developed specific antibody. This particular complementary DNA probe developed PS5 antibodies, which will react specifically to only non-A, non-B hepatitis and not to hepatitis B or hepatitis A. Moreover, this antibody will be present only once the incubation period is over. Look at the initial presentation in patients. There was no hybridization. The hybridization was occurring only when the antibodies were proved. So this was proven that you have a specific anti-HCV antibody against the clonal DNA called fragment 511 and C81. So this was the first concept which clearly showed that after the construction of the complementary DNA library, they were able to show encoding of an antigen which was a single-stranded RNA produced from this complementary RNA consisting of about 10,000 nucleosides. It was a positive stranded RNA, and it was from a family called Toga virus family because of its size. So for the first time, they gave us the molecular approach, which they thought will be useful for isolation, characterization, and identification of the unknown agent. And subsequently, thanks to their discovery, both Horton as well as the Harvey Alter, they came up with this kit, which was called, they named the virus as hepatitis C, and by 90 in US, they started using the kit for screening of hepatitis C patient before blood transfusion. Subsequently, in 1991, ribavirin was used because it was a non-specific agent. It was one of the agents. This was from Sweden. This was a non-specific antiviral drug. This was not an injectable drug. It was a non-interferon-inducing drug, which was effective against most of the RNA and DNA viruses. So they tried to use it in patients with so-called hepatitis C now, because by that time hepatitis C was discovered, and they showed a marked improvement in aminotransferases. But the only problem was that once you stop ribavirin as a monotherapy, there was almost universal recurrence of the symptoms. By 1997, then came this gentleman called Charles Rice, as Dr. Chandrasekhar has told us, that the third gentleman to receive this award is other than Harvey Alter, Michael Horton, and third gentleman is Mr. Dr. Charles Rice. What he did was that he was the first man who showed that inoculation of the infected material, which was transcribed from the samples given by Harvey Alter and the Michael Horton, were injected deep into the liver of the chimpanzees. So a single-stranded RNA virus weighing this much, which had both the 5' and 3' component, was subsequently injected into the chimpanzee's liver, and it was found to be infective. So since for any infectious disease, you need to have a complete proof that the infection has to be occurring because of the presence of virus within the tissues. So they were awarded the prize for discovering this agent. But still, there was some limitations because there was a poor replication in the cell culture. You had a restricted host range because other than chimpanzees, no other animal could be taken up for the studies, and you have lack of infectious molecular clone because of the high variable quasi species which were present in this individual. Subsequently, they showed that if you collect the sample and analyze, there was a lot of heterogeneity in all the samples which were collected. And this was the reason why we were missing some of the samples, and the sensitivity was not available till then. So addressing these challenges, then came the isolation and characterization of the same H77 strain from the gentleman who had already donated his 500 ml of the blood in 1977. And they showed that there were various components of virus which were identified. And by now, subsequently, the cycle of the hepatitis C virus was documented and different clones were picked up. So by demonstration of infection from the infected individual into the liver of the chimpanzees, one was able to clearly show that this was infection occurring because of one single agent occurring with the consent of the human beings as well as the inoculation into the chimpanzees. So with this, we have a documentation of hepatitis C virus getting transmitted by the clonal expression of the isolated complementary DNA fragment which were obtained from the infected human as well as the infected chimpanzees. So the fact that this was an enveloped virus was further documented by this lysis with ribonucleases. So if you lyse the serum with ribonucleases, we know it is an RNA virus, and hence it is not a complementary DNA virus. So for the first time, we had documented that this is an agent which has been transcribed and has been documented to be infected, and hence Charles Rice was given Nobel Prize for this discovery. Then came the natural history of hepatitis C. As all of us know that Thierry Poinard was from France, and he had an excellent work which presented the good history of hepatitis C. So he took up multiple groups of hepatitis C, and after studying 2,200 patients with hepatitis C, at that time called to be non-A, non-B hepatitis, and came up with 5 factors which were associated with progression of the disease. Age, more than 40 years, concomitant alcohol intake, male sex, and larger duration of the infection. And by now, we still know and we still remember by heart that out of the 100 patients who are infected with hepatitis B, 20% will have spontaneous resolution, 80 will go into the chronicity. Those with chronicity, 35% will remain stable. And of those with progressive disease, with cirrhosis, 20% will develop hepatocellular carcinoma or liver failure. So this type of natural history was given by Professor Poinard, collecting the data from non-A, non-B hepatitis, even when the hepatitis C was not discovered. So when the H strain of this gentleman who had donated initial blood was analyzed, it was seen that there was 67% of the dominant clone, and there were multiple variants which were subsequently referred to as species and subspecies. And it was seen that you had specific antibodies which were occurring only to the species. So with availability of the various diagnostic methodologies which were developed by Kirion Corporation, we were able to specifically develop the engineering clones which were useful for diagnosis of hepatitis C as well as for utility of hepatitis C in the various cultures. So this is how the hepatitis history goes on. You had in 1987, there was some clue to the presence of the infectious illness. Harvey Alter discovered the virus. It was started screening in the blood transfusion in US in 90. First interferon was used by Hufnagel in 1991, and subsequently discovery of hepatitis C cycle gave us a clue as to how the virus replicates. Stephen Zoyson was the first man who thought that why not give pegylated interferon? Because compared to pegylated interferon, which had a short half-life, this is a half-life of almost 7 days. So you have continuous interferon levels in the blood. And using this technique, he convincingly showed that if you give pegylated interferon in various types of hepatitis C viruses and various genotypes, you almost double the clearance rate and SVR as was presented at that time. Subsequently, we had a publication from Dr. Michael Mann's group from Germany, who clearly stated that with various publication in various international journals, that if you end up adding a drug called ribavirin coupled with pegylated interferon, then you can still jack up your overall sustained virological response rate to the tune of about 60 to 70%. So he used he had around 1,530 patients randomized into different groups. He used a combination of either pegylated interferon, low dose, high dose, with or without ribavirin. He used multiple groups, and these were the various groups he used. And ultimately, what he found was that the best results were obtained in patients who were given a good combination of pegylated interferon, high dose, coupled with ribavirin. So they also came up with this new prognostic factors. The genotype 1 was difficult to treat, high viral load was difficult to treat, higher obesity was difficult to treat, older age was difficult to treat. I'm sure Dr. S.P. Singh and Dr. Chandrasekhar would remember for next 10 years, we did hang on to only these prognostic parameters, and we had nothing else to do but to give our patient pegylated interferon coupled with ribavirin to increase our SVR to a tune of about 60%. That is the best we can achieve. So there was a complete lull between 2010 and 2012. So between 2000 and 2012, till this new publication came from Dongliang's group, who thought of a new concept called IL-28B. This was a gene which was discovered, which predated and which antedated the area. It was a polymorphism gene which resides 3 kilobyte upstream of the IL-28B gene. That means it will encode for interferon lambda. That means anybody who has this gene was more likely to have sustained virological response. And anybody who has this CC type of response for the gene, IL-28B gene, then that gentleman had more likely chance of responding to therapy. So all of us, I'm sure most of my colleagues would remember that we'll send the sample for IL-28B just to tell our patient as to what is going to happen over a period of time. And this had already been shown clearly that why Asians do respond better than the African Asians or European, which were in the middle group, was because of the difference in the frequency of alleles of IL-28B in the different parts of the population. So for 2 years, we kept on hanging around with this technique of looking for pegylated interferon, ribavirin coupled with IL-28 till this life cycle of hepatitis B was discovered. Just to tell you the brief history of
single-stranded RNA virus whose genome encodes a single polyprotein of 3,000 amino acids. The protein is then processed by both host and viral proteases into structural proteins and non-structural proteins that assist in viral replication. Several steps are fundamental for HCV to infect a cell, replicate, and then release to infect other cells. Each of these steps is a potential target to interrupt replication, rendering this virus inactive. The HCV RNA is surrounded by an icosahedral shell of protein, which is then surrounded by a lipid envelope made from modified host cell membrane. Although the exact mechanisms of HCV cell entry are still unknown, it's thought that the envelope proteins on the surface of the virus bind to host CD81 and other cellular molecules, allowing HCV internalization. Once bound, HCV is internalized through endocytosis. The plasma membrane folds inward, bringing HCV into the cell. HCV travels through the cell cytoplasm to the rough endoplasmic reticulum. Ribosomal subunits associated with the RER serve as translation units, converting the message coded in the mRNA to a specific sequence of amino acids. the HCV polyprotein. Translation of the HCV genome results in a large polyprotein that is then cleaved by host and viral proteases.
So once this life cycle was clearly delineated, then there was a sea of advantage and opportunities for the scientists to come up back and discover the various drugs. And after that, you have the history to see the way the treatment of hepatitis C has taken a sea change. And I think the biggest contribution was from this single drug, which is a nucleoside inhibitor called sofosbuvir. This is a publication of New England Journal of Medicine, which showed that irrespective of type of hepatitis you are talking of, irrespective of the group which were being treated for hepatitis C, whether they were treatment failure or treatment naive, irrespective of the type of genotypes and irrespective of the liver status, all these patients had excellent response to ribavirin therapy when you are adding ribavirin as a therapy. It has been clearly shown for the first time by Edward Jane that a single therapy, monotherapy with 8 weeks of sofosbuvir will almost lead to complete inhibition of the virus, which is sustained for a long period of the time. So for 12 years, we were banking upon 60% response rate with pegylated interferon, ribavirin, and the response rate to IL-28 gene till this new concept came in. So this new concept of sofosbuvir coupled with other agents which were acting against NS5A, NS5B, and the nucleoside inhibitor did change the whole scenario. And then we were talking of almost 90 to 100% response rate, even in patients who were being treated in a resistant manner or who had been treated. So to sum up, ladies and gentlemen, we started the discovery of hepatitis B virus way back in 1984, even though non-A, non-B was being diagnosed on epidemiological basis for a long period of time. Subsequently, with the advent of various diagnostic modalities and the attempt to use the various combination of initially regular interferon, pegylated interferon, the major sea change came with discovery of this agent called sofosbuvir. And subsequently, the newer complexes against NS5A inhibitor and NS3 protease inhibitor have led to a stage where we are already talking of elimination of the virus. So just to give some tribute to the discoverer of sofosbuvir, this was discovered in 2007 by Michael Sophia at who was a pharmacist in the now so-called Gilead Society. Once they had been given the FDA approval for its use, there was a high-profile patent lawsuit which involved Gilead and the drug giant Merck. And federal jury did order Gilead to pay Merck about US $2.54 billion. So you see the way Gilead had to bunk up the charges which they had obtained for getting the patent for this drug. So with passage of time, you have newer and newer agents which came into treatment for hepatitis C, and now we are already looking at elimination of hepatitis C. So recently, WHO said that if you are able to decrease the incidence of hepatitis C by 90%, you are going to have elimination of virus hepatitis C from the world by 2030. But that will require a plethora of events, of which Dr. T.S. Chandrasekhar is doing a good job of having social components to elimination other than the medical therapy, these including sustaining funds, maximizing the treatment size, optimizing clinic care, extending the screening facilities, extending the treatment pool, and giving the excellent therapy. What have we achieved in India? We started the blood screening program in 2002. We have launched the National Viral Hepatitis Control Program in 2018. And this was, I just cannot skip mentioning this excellent publication from Dr. Dhiman's group, who have produced a word rating model called Punjab model for eradication of hepatitis C. You know, Punjab, called the Urta Punjab, is a den for hepatitis C, and the type of work done by Dr. Dhiman certainly would add our efforts to eliminate hepatitis C from the world. So Punjab model has given us an excellent way of treating, diagnosing, and quickly getting on to the remote areas to get the virus away from us and achieve the goal of hepatitis C elimination by 2030. To sum up, ladies and gentlemen, 3 people who really changed the scenario of hepatitis C, including Harvey Altered, who took the blood from this H and 5 other gentlemen, injected into the chimpanzees and produced non-B hepatitis. Professor Michael Horton then took the genetic material from the infected chimpanzees, then they cloned a complementary DNA probe, took the antibodies from the infected individual and proved that it was a single-stranded RNA of about 10,000 nucleoside. And finally, the proof of the pudding lies in eating, and that was given by Professor Charles Rice, who injected this complementary DNA and the infected agent into the chimpanzee's liver and produced the viral hepatitis picture. So ultimately, we have a very short half-life of the hepatitis C. I've never known an agent which was discovered at the time when we were finishing our DM, and it is going to be out of the word by the time we close our eyes. So this is just like a matchstick which is just getting lightened up and getting extinguishing between 1989 to 2030. Thank you.
Thank you, Dr. Arora. What was a very masterly presentation of the life of HCV, taking it through the journey of HCV. Dr. DSV, do we go to the questions now?
You did a wonderful job, Anil. This is, as LVK put it, is a masterly delivered lecture, and this is what you said is true. When I just joined DM, non-A, non-B hepatitis, now over a period of 35 years, this is almost like typhoid fever now. You give the medicine, 98% cleared. It is like less than tuberculosis. Tuberculosis, at least you need to have 6 months therapy now. But here, 45 days or 6 weeks therapy also were good. And the way you traced it from the Harvey Alter did it now, it is a phenomenon. The only thing I want to add here is the Harvey Alter, initial days he worked with Dr. Plumber. He the one, and he got inspired, and he was part of the team when Blumberg discovered hepatitis B. This is the only thing. So what is the lesson is, where do you join and with whom you work is very important. That's what lesson I learned. And fantastic, but all the questions now already we have 25 questions for you, but we'll take up after the lecture by Dr. Akash Shukla. Now we'll call upon Dr. Buldas to introduce the topic and Professor Akash Shukla.
Thank you, sir. Am I audible?
Yeah.
Thank you, sir. It is a wonderful series you started by you, and congratulations from society and behalf of me. From a Nobel topic to the potential Nobel winning topic, that is NASH, that is we are going to discuss next. And it is called one of the silent pandemic of this century. What Corona is doing is an acute pandemic, but NASH is a silent pandemic. Now, just now we have a talk by Anil Arora said, where we have seen a similar disease where it was discovered and it was cured by over 35 years. Whereas NASH is also have a similar profile, which was discovered around 1980s, but still we are not in a dark spot. It is one of the modern disease which was discovered in 1980s, which started with a simple fat accumulation and lead on to fibrosis and cirrhosis, leading on to death. They say it is the most prevalent liver disease in the human history, and one of the leading cause of death in the 21st century by like a cancer, diabetes mellitus, and IBD, and coronary vascular disease. They say by 2020, that is by the end of this year, it will be the leading indication for liver transplant in US. So it is like a part of metabolic disease like diabetes and hypertension, but we don't know what is the obvious symptoms. We don't know how exactly we can diagnose, and obviously there is no specific drugs. For many, fatty liver is a simple stay and go and never be a problem. But why it is some people it is giving so many problems. So I think there are so many interesting factors for NASH. I am introducing a speaker who is also part of our editorial board of GHEP. We are proud to call Professor Akash Shukla, who is professor and head of Department of Gastroenterology in Seth and KM Hospital, and he is also a consultant hepatologist and a transplant physician and global hospitals. He's a joint secretary for the Zonal Transplant Coordination Committee for Mumbai, member of steering committee of VALDIC, and head scientific committee Gastroenterology Society of Mumbai. He's also a governing council member of NAFLD. And he's also an editor of a book on NAFLD. So he's a ideal speaker for on this topic. More than
Can you speak a little louder and closer to the mic?
And he has more than 71 research papers. He has also have a lot of achievements. He is a International Achievers Award and the Young Gastroenterologist Award in 2017. And he's gotten a plenary award in Asia Pacific Liver Association 2018. And in the last 10 years, he got almost 4 best papers in the ISG Con. Over to Dr. Akash Chukla.
Unmute yourself, Akash. Okay. Can you share the screen? Can you unmute yourself? Akash?
Am I audible now?
Yeah, now only audible. You can start right from beginning.
Good evening, everybody. Thank you, Professor Das, for those kind words of introduction. At the outset, I would like to thank Dr. T.S. Chandrasekhar and MedIndia for giving me this opportunity. All these years, I've been writing papers, research papers, and got so many rejections. Thank you, Professor Chandrasekhar, for giving me the opportunity to get the power of rejecting a lot of papers published in Science and Genetics and NEJM. So for the first time, I felt powerful enough to reject some of those papers when I was selecting these 10 papers. On a lighter note, but the biggest challenge for me was to choose 10 papers, as I was sharing with Dr. Chandrasekhar previously. And eventually, I decided to choose 10 papers which were clinically relevant. And I deliberately did not include basic science papers, because that would be another 10 sessions of another 10 papers, which will probably be of equal importance, if not more. And with that, I would start with the story. And like Dr. Das said, that the disease was diagnosed only in the 1980s. But this is a wonderful paper published in 1952 by Professor Samuel Zellman. And it's a very interesting story, how he thought of looking at liver in obese people. He had a ward boy in his hospital. He was a veterans, he was working in a veterans hospital. He had just retired from the army and he was working in the veterans hospital, and he looked at one of his ward boys who used to drink more than 20 Coke in a day. And he wanted to look at his liver functions, and he found them to be deranged. And that's how he decided to do his first study of looking at liver functions in people who were very obese. And almost 20 people he assessed, and he described liver function abnormalities in obese people who had not been consuming alcohol. Professor Zillman wrote this in 1952. He died in 2007 when he was 98 years old. And as per his obituary, he was still fully mentally functional till the last time of his death, and was an avid writer and poet. And I'm sure he must have been fascinated by looking at the journey of the disease, where he wrote the first paper almost 70 years ago. We are all aware of this landmark paper from Ludwig, who talked about NASH and giving it the name NASH, non-alcoholic steatohepatitis. This is the most cited paper in the field of non-alcoholic steatohepatitis, where they looked at 20 patients with NASH of unknown cause. They discussed the fatty changes. They described lobular hepatitis, mixed inflammatory infiltrates, presence of Mallory bodies in the absence of alcohol, presence of fibrosis, as well as cirrhosis. They also described that it was more common in women who were not drinking alcohol and were moderately obese. But if you look at the publications, 1 year prior to Ludwig's paper, this was a wonderful paper published by Adler and Scheffner from Mount Sinai. It was called as the fatty liver hepatitis and cirrhosis in obese patients. 29 patients were studied in a selected group of those who were not having alcohol, and they found 4 important pathologies: fatty liver, fatty hepatitis, fatty fibrosis, and fatty cirrhosis. And they found that diabetes was common. Presence of fat was associated with lipoprotein abnormalities, especially hyperlipoproteinemia, and the pathology resembled that of alcohol as well as post-jejuno-ileal bypass. And these were the photographs which were provided, the photomicrographs, and steatosis, steatohepatitis, the central and portal zone changes with inflammation and fibrosis, and presence of cirrhosis. In fact, the description of these biopsies is so similar to the paper published by Elizabeth Brunt almost 20 years later that you often wonder why this paper is not so often cited. Exactly what Elizabeth Brunt had said. They had not only described these changes, but also graded it very much the same way, like Elizabeth Brunt had done 20 years later. So they had graded the amount of fat, the amount of necrosis, inflammation, presence of fibrosis, bridging fibrosis, overall inflammation, as well as glycogenation of the nuclei. One more interesting thing, they also described that SGPT was more than SGOT in these patients, and that there was no correlation between the enzymes and the amount of inflammation on liver biopsy, something which took almost 20 to 30 years for the rest of the world to realize. So very, very interesting paper. I think understated, but had a huge impact, because I'm sure all people who have worked on NAFLD would have read this paper and got their original thoughts based on this paper. So here now we knew in the early 80s that there is a disease which is present in obese. Some of them have fatty liver, some of them have inflammatory hepatitis, some of them have cirrhosis, but we still didn't have proof that the disease could progress from just steatohepatitis to fibrosis to cirrhosis, or from steatosis to steatohepatitis and fibrosis. And in this paper, published by Elizabeth Powell and her group, The Natural History of NASH, a follow-up study of 42 patients for 22 years, published in Hepatology in 1990, these were the 42 patients. For the first time, we realized that a lot of patients would remain stable. That means if they were in this phase of steatosis, they will remain steatosis. If they had steatohepatitis, they would remain in the category of steatohepatitis. But some patients will progress from steatohepatitis to fibrosis. Some patients who had fibrosis will develop cirrhosis. Also, like the patient number 41, some patients will die not because of the liver disease, even if though they have significant liver disease, but because of myocardial infarction. And where the patient lose weight, the liver condition also improves. So this was the first longitudinal study which demonstrated all these changes. Interestingly, they had paired biopsies or multiple biopsies in some of the patients. For example, the first patient here, that is patient number 30, had cirrhosis to start off. This patient, in around 4 years, developed hepatocellular carcinoma and died 1 year later. So this is where longitudinally it was shown that patients with NASH cirrhosis can progress to HCC. The patient number 31 started off with inflammation, fat, and fibrosis, and went on to develop cirrhosis around 4 years later. Similarly, patient number 41, despite the presence of NASH, died not because of liver disease, but because of cardiac disease. The conclusion of this paper was that this disease, NASH, is slowly progressive and of low grade severity, which till date we agree that in a majority of the patients, it's slowly progressive and low grade severity. But it may ultimately result in cirrhosis, and NASH should be distinguished from alcoholic steatohepatitis and recognized as a further cause of cryptogenic cirrhosis. This line has impacted us so much that most people believe today that all cryptogenic cirrhosis are probably NASH cirrhosis. So we now know that it's a slowly progressive disease. We are now in the early 90s. We know some patients will progress. So the next question came, who is going to progress? And to answer this question, we had this paper in hepatology published by Angulo and Keith Lindor and the two other co-authors. When they did a univariate analysis, they found the usual culprits like age, BMI, obesity, diabetes, AST-ALT ratio, low albumin to be associated with severity of liver fibrosis. But when they did multivariate analysis, 4 things which were found to be significant, which till date remain the strongest predictors of liver fibrosis in patients with fatty liver, are obesity, advanced age, presence of diabetes, and AST to ALT ratio of more than 1. And that is why they came up with this algorithm that you stratify your patients first by age, less than 45 years or more than 45 years. Less than 45 years, there's a very small chance of liver fibrosis, and that is only if the person has obesity or diabetes mellitus. Above the age of 45 years, presence of obesity and or diabetes mellitus would be associated with almost 2/3 chance of liver fibrosis. And I think this is a very useful way of stratifying patients. And I think even today in our OPD, we look at these parameters before we take a call. So these were the factors, but these were all non-modifiable factors, except for probably obesity. And there had to be something else other than these factors to define who is going to progress and who is not going to progress. And after the JIVA studies and looking at the association of various genes with obesity, this landmark paper published in Nature Genetics looked at the genetic variation in PNPLA3 and demonstrated that it confers susceptibility to non-alcoholic fatty liver disease. So this was the patatin-like domain, the I148M mutation, and they demonstrated that it was associated with increased triglyceride content of the liver, but did not correlate so much with the BMI, HOMA-IR, or the plasma triglyceride levels. This hepatic triglyceride content, because of the I148 mutation, correlated the highest in patients who are of Hispanic origin. The additional thing which they described was the gene, the allele S4531, which was associated with a lower hepatic fat content, and this was especially in the African Americans. So this was a protective mutation which was also found. And that could explain why some people, despite being massively obese, never had progressive NASH or cirrhosis. So this is how they concluded in a population of over 9,000 patients that one allele, the I148M, was associated with increased hepatic fat levels and inflammation, found most commonly in Hispanics, and the other mutation was associated with lower risk of hepatic fat content and was protective for development of NASH in a certain population, especially African Americans. So all these while we were diagnosing these changes on histology, and therefore it was natural that there was some uniformity in reporting across the world. So the two pathological twin papers, and they were pathological twins because there were two papers which were related to each other in the field of pathology of NASH. The first was by Elizabeth Brunt and her colleagues from St. Louis, Missouri, and this was published in American Journal of Gastroenterology in 1999. And they looked at 10 important features and tried to score them, like macrovascular steatosis, hepatocellular ballooning and disarray, lobular inflammation, portal tract inflammation, Mallory hyaline bodies, acidophil bodies, pars D Kupffer cells, glycogenated nuclei, absence of lipogranuloma, and hepatocellular iron. And based upon this, they graded the disease into mild, moderate, severe, or grade 1, 2, 3. And also, they scored the liver fibrosis. Perisinusoidal fibrosis scored 0 to 3, portal fibrosis scored 0 to 4, and bridging fibrosis scored from 0 to 4. This was given a more formal and a simplified system, which was called as the histological scoring system for NAFLD, which was by Cleaner and Elizabeth Brunt, which was in 2005 as part of the Non-Alcoholic Steatohepatitis Clinical Research Network. This comprised of 14 histological features, 4 of them being semi-quantitative, the steatosis, lobular inflammation, ballooning, and fibrosis. The rest of the 9 features were recorded as present or absent. Not only that, they also looked at how should we really define NASH. And they came up with 5 features which were considered to be diagnostic. And this has not changed till now. Steatosis, ballooning degeneration, lobular inflammation, fibrosis, and absence of lipogranuloma. So almost all papers after this have used this scoring system. This was called as the NAS score, non-alcoholic steatohepatitis score for diagnosis of, or for scoring of the pathological changes in patients with NASH. Even today, when we are faced with problem of scoring, all we need to look back is these 3 pictures, which gave such a beautiful impression in the minds of those who saw this, of how to score ballooning regeneration. In A, you can see very scant inflammation. There is hardly any ballooning. Almost all cells that you are seeing enlarged are just steatotic cells. Whereas in the second, that is in the B, you can start seeing that there is ballooning, which is beginning to appear, but only in occasional ones. Now, interestingly, when they started off the consensus, this was the one where major debates happened, and they had initially classified this into either mild, no, or severe. Some are classified into no ballooning, some are classified into severe ballooning. And that is when they developed a consensus and came up by saying that this is what will be called as grade 2. And here, which is obvious that almost all the cells are ballooning, this will be called as severe. So this is how the scoring developed. And even today, this is how we score ballooning and make our diagnosis. They also described the microvascular steatosis and the presence of megamitochondria and the importance of these in prognosis. Even today, I think this paper holds a lot of relevance. Another problem with this paper was they showed that when the NAS score, the NAFLD activity score, was 5 or above, then the diagnosis of steatohepatitis was most likely. Unfortunately, it was used to diagnose steatohepatitis in many of the studies, while that was never the intent. So you can have NASH even with a NAS of less than 5, and you may not have NASH even though the NAS is more than 5. So this was one of the problems which were started by this paper, which Elizabeth Brunt herself clarified in a later paper around a decade later, that this is not what they had meant when they wrote this paper. Till this time, we were all dependent on biopsy for diagnosis, and we all know it is impractical to do biopsies for all the patients who have liver fat and to diagnose or to prognosticate NASH. And therefore, there was a need for a non-invasive technique. And the first major paper, this technique actually brought the diagnosis of NASH to a common practitioner. The transient elastography, a new non-invasive method for assessment of hepatic fibrosis. So Sandrin had just finished his PhD on transient elastography. After that, he actually started this company, EcoSense, and came out with this paper where they found that FibroScan was very useful in assessing stiffness of the liver. These images have now become so common, and we are all used to seeing these images now in our daily practice. He described the progression of waves to be oblique in patients who have F0, and as the fibrosis progresses, the progression becomes more and more vertical, and then they could actually quantify it using a logarithmic scale and show there was a significant separation in those who had F4 fibrosis as compared to those who had F2, F3 fibrosis, as compared to those who had F0, F1 fibrosis. And the area under the curve exceeded 0.88 for all and was 0.99 for F4 fibrosis. Of course, we now know that it is no longer 0.99, but even then, I think it is the single most important tool available which has to clinicians to make a quick diagnosis of fibrosis in patients with NAFLD. A useful addition to this was the CAP, which was a controlled attenuation parameter, which looked at quantification of steatosis. While the strain image gave the liver stiffness, it was the ultrasonic frequency data which gave the control attenuation parameter algorithm and the CAP value. And for the different steatosis stages, there was a nice separation of the CAP values, and you could diagnose stage 2, stage 3 and contrast it from stage 1 or no steatosis. The area under the curve were again excellent and more than 0.9 for all the stages of steatosis. So we had ways and means to assess the severity of disease. We had a non-invasive way. Now it was time to look for treatment. While it was common sense that if obesity is associated with development of NASH, then weight loss should improve the pathological features of NASH. But it was formally found out only in this paper where it was quantitatively defined as to what will be the appropriate amount of weight loss which will be significant. If you see here, they started off with a predefined endpoint of 7 to 10% of body weight change. That is loss of around 7 to 10% of body weight over 6 months period. 6 months to a year period. And if you look at the controls, that is those who were not offered the lifestyle modification, there was hardly any change in their NAS score. But if you look at those who were offered the lifestyle and those who achieved significant weight loss, more than 7%, they achieved at least 3-point improvement in their NAS scores and had a significant pathological improvement. So they improved their LFTs, they improved their NAS score by at least 3 points. What were the changes that were seen in histology after 1 year of intervention? Fat loss as expected. Also, the ballooning improved significantly. The NAS score improved, but not the fibrosis. If you look at those who lost more than 7% body weight as compared to those who lost less than 7% body weight, the amount of initial weight did not matter. Presence or absence of diabetes and use of metformin did not matter. But if somebody lost more than 7% body weight, their fat was lower, their lobular inflammation was lower, ballooning was lesser. The fibrosis also, there was a trend towards being better, but it did not reach statistical significance. The NASH score was significantly better, and the improvement of proportion of people with at least 3-point improvement in NASH score was also better. NASH score of less than 2, which is like complete remission, was also much higher in those who achieved 7% weight loss. And that is how the target weight loss of 7% was defined after this. And that is what till today we advise all our patients. What about drugs? We have all been using vitamin E, and this was the paper which told us that vitamin E or pioglitazone are useful. Published in NEJM in 2010, almost 83 patients in placebo arm, 84 patients in vitamin E arm, and 80 patients in pioglitazone arm. They showed that patients with vitamin E and pioglitazone have a significant improvement in their histology. The steatosis improves with both vitamin E and pioglitazone. The lobular inflammation improves with both these drugs. The ballooning improves with both these drugs, but there is no improvement in liver fibrosis. The resolution of definite non-NASH also happens with both these drugs. They also demonstrated improvement of enzymes with both these drugs, but the improvement in insulin resistance, as expected, was only with pioglitazone and not with vitamin E. The major side effect of pioglitazone, that is weight gain, was demonstrated in this study, while vitamin E did not impact the weight of the patients. And that is why pioglitazone was not found to be favorable by most of the end users because of this side effect. Coming to the latest study, which I would included, it is about the Regenerate trial. And I'll tell you why I included this study, why this is a landmark, because this for two reasons. One, this has changed the endpoints that we are looking at, both from the fibrosis point of view, as well as from the point of view of resolution of NASH. We have only interim analysis of this study published in Lancet last year. For the first time, we had a drug which showed improvement of fibrosis, although it happened in 23% of the patients. But very interestingly, because these patients were given good lifestyle modifications, there is an improvement even in the placebo arm of around, so 12% people in the placebo also had an improvement in liver fibrosis. We all know one stage improvement of fibrosis can be just a sampling error of biopsy. And therefore, this paper also looked at fibrosis improvement by at least 2 stages, and that happened in 13.3%. So it didn't happen in all. It happened only in every 7th patient. But for the first time, we had a drug which could reverse the liver fibrosis by at least 2 stages in a small cohort or in a small subgroup. Interestingly, none of the dosages showed NASH resolution, neither when you looked at intention to treat, nor when you looked at per protocol analysis. And this was very interesting. If NASH is not getting resolved, what the FDA realized was it was very difficult to say that there is absolutely no ballooning, because that is what the definition was for NASH resolution. And therefore, for the first time, the endpoints actually were changed slightly. And another factor which was added was NASH improvement by at least by score of 2 with no worsening of fibrosis. And that was found to be significantly better with 25 mg of obeticholic acid as compared to the to placebo. Similarly, hepatocellular ballooning improved by at least 1 score, lobular inflammation improved by at least 1 score, and of course, we already discussed the improvement in the liver fibrosis. So to summarize, my dear friends, in this journey of almost 70 years, if we take Professor Zellman's work, but around 40 years, in the last 4 decades, major advances have been made in the identification, understanding, and prognosticating non-alcoholic fatty liver disease. But we have major lacunae in the therapy even today. Unlike hepatitis C, we still do not have a good drug for treatment of hepatitis, for treatment of non-alcoholic steatohepatitis. But there is a light at the end of the tunnel. We are now looking at drugs which can reverse fibrosis. The benchmark has already been set, and therefore, this is the minimum that all the future drugs will have to at least meet. We also realize that we are looking at a holistic approach, with lifestyle modification being an important pillar rather than a wonder drug which will solve all the problems. Unless, of course, we are able to see the light of the day for a drug which is a liver-specific mitochondrial uncoupler, which I would leave the discussion to another day. Thank you very much, and I'll be happy to have any discussions.
Thank you, Akash. That is a wonderful lecture, and I think you walked through the spectrum of NASH development over a period of decades. And I think over to Professor TSC.
So you need to unmute.
Thank you, Bal, for coordinating this talk. Akash, well done. Congratulations. And you said you have read the article thoroughly, and all the 30 articles. Then you have the difficulty in choosing 10 articles. So I think you took us a journey. I think what Dr. Anil Arora would agree with me that what we were hepatitis C 30 years before, now NASH is like that. Still, there is a lack of treatment modalities available. Like that, when I think Anil will recall that in the early 80s, when we used to give a talk, non-A, non-B hepatitis, God only knows what is this agent. Nobody knows what is the treatment now. Now, over 95% cure rate in hepatitis C. Unbelievable. So, NASH is going to be with us till we eradicate it. The first question, I have 127 questions, but what we have done is we have my colleagues have chosen at least as many questions we can take up. The last one I want to ask first, Akash, is if you are given all the facilities, do research. And what work will you carry over in NASH? No limitation of fund. You will have the best brains here.
So I think I would look at in fact, I did mention it in the last line that I would look at evaluation or development of a drug which is a liver-specific mitochondrial uncoupler. To explain this, I would give an example. If you leave your car engine on and sit in the AC inside it and don't move the car, after 4 hours, you'll burn out all the fuel and there'll be no fuel left. This is exactly what this mitochondrial uncoupler will do. There'll be beta oxidation happening, but there'll be no ATP production. So if we can restrict it to the liver somehow and not escalate to the rest of the body, then the liver will keep on generating small amount of heat, keep on consuming the extra fuel that we have consumed, and we will be cured of obesity, NASH, and everything. So that is what I would want to research on in the future, if ever there is an opportunity.
So fuel will be exhausted, but there won't not be any movement.
So yes, so even without exercise, without lifestyle modification, you will actually get a cure.
But people will become more lazy, no? They will again
I think the society is likely to become more lazy now, especially with with where we are heading.
Yeah.
With the technology coming in, it's inevitable.
Yes, give me a chance to research in a situation like this.
Yeah, what will you suggest, Dr. Anil?
Yeah.
So you have now taken off all your thing and given the best possible lab, and funding is no restriction. Can you?
I with this gentleman called Elon Musk. and ask him to unravel the mystery of energy homeostasis. I will ask him, why is it that you are allowed to put in so much into the liver, so much into the subcutaneous tissue before you react at the fag end of, say, mitochondrial uncoupling? Why can't we handle our appetite, our energy homeostasis, our hypothalamus, so that we don't eat that much, or we are not allowed to store energy? I think working at the fag end of mitochondrial uncoupling, you should understand, mitochondrial oxidation is one of the evolutionary mechanism which has produced life. There is no way if you can undo that life will go away. You see, this is the only evolutionary step in which two organisms had joined. After all, what is mitochondria? Mitochondria plus cell from the eukaryote, prokaryote had produced eukaryote. Mitochondria itself is an organism with its own DNA. So I think it is undoing the nature. So look at the hypothalamus, take care of your energy homeostasis. Do not allow the fat to be stored first rather than occurring at the fat end. That is what I'll do.
You would start from the beginning itself.
I'll start from the beginning.
Storing the fat in liver.
Yes,
And
rather,
he says, after whatever may be the reason may be difficult, once the fat is deposited, I will burn the fat without whatever may be the thing, and I will ask them, will not produce, before it damages, it will burn the fat. So this is a two extremes. I think it both sounds good only. And the compliments to both the speakers. I have several people have said excellently spoken and difficult topic, and difficult to choose the 10 publications. So what was your difficulty, Anil, preparing this topic?
yeah, you see, I think I didn't have much difficulty because I had already thought, so it was very easy for me to choose all those people who had got the Nobel Prize. After all, the Nobel Prize committee certainly is smarter than me. So they would have chosen it basis of something. So that is something which really helped me. And then once I was able to choose those topics, I tried to make a link of the thought process about non-hepatitis. You'll remember, TSC, that one of my colleagues, Dr. S. Dasrathi, who was from JIPMER, me and we did our DM together. Now he's a big guy in sarcopenia in Cleveland. We were together in DM, and his thesis, was on post-transfusion hepatitis in All Institute of Medical Sciences.
Oh, very good.
And we finished in 89, and immediately, as soon as we finished, we had this Kirion Corporation coming up with that.
So that was in the making of Nobel Prize now. Dasrathi should make. Okay, now the question is to Dr. LVK. They asked a question: do you see acute hepatitis C? If so, how frequently and what should be done?
We don't really see acute hepatitis C, but we see in a high risk thing. In our center, we see it in our patients who are on hemodialysis, and there is a persistent transaminitis. And when you have a persistent transaminitis, we should remember in patients who are hemodialysis or sometimes in HIV, their antibody may not be present, but in that case, you need to check their HCV RNA. So if patients are anti-HCV negative and they have a recent transaminitis which is persistent, and if they are HCV RNA positive, of course you can probably diagnose acute HCV.
Okay, so you don't see that frequently. What is the treatment you offer for? Suppose you say HCV RNA is positive
and HCV negative.
We can
I think we now recommendation is we can give a pan-genotypic direct antivirals, and they do respond very well to this. In fact, acute HCV, even during the time of interferon, used to respond very well about to 90% of the times. But with this recent oral antivirals, they respond very well to this.
Dr. Sanmaganandan is asking question to Dr. Anil. What are the preventive measures to be taken against hepatitis C? Is it like hepatitis B or what else more? How frequently they sexually transmitted C virus? Whether does it come under STD, sexually transmitted diseases? This is by Dr. Sundaramurthy. All three you can take it up.
You see, the major transmission of all parenterally transmitted viruses are the same. The major source of transmission is blood. Rest of the non-blood related transmission sources are more robust in hepatitis B because you require far less infectious zone than with hepatitis C. Hepatitis C certainly can be transmitted by all those means by which hepatitis B can be transmitted, but usually it requires larger infectious dose. Thirdly, it is known to be transmitted by the sexual route, and it is clearly classified under STD also, but the rate of transmission is not more than 5% overall as compared to hepatitis B, depending on its infectivity. And the preventive measures are the same. You do not have to reuse the needles. Now, luckily, we have excellent sensitivity, specific, the diagnostic kits, third generation ELISA kit for screening of hepatitis C. Blood transfusion hepatitis is extremely uncommon unless you are giving commercial blood. I'm sure Dr. TSC and Akash, maybe TSC will remember that when we were doing our DM, a lot of people in AIMS used to get the blood from a commercial blood bank called Sunil Blood Bank in front of AIMS. But thanks to discovery of hepatitis C, there has been a clear indication from the notification from Government of India that nobody is allowed to use a commercial blood. It has to be a voluntary blood, which will decrease the incidence of hepatitis C related to blood transfusion. So all those measures like reuse of the syringes, tattooing, acupuncture has to be done through the disposable needle. That will practically prevent. Hepatitis B is something which can be totally prevented by vaccination, unlike C.
A question from Dr. Hanumantaya is, C virus was detected later than B virus. Now you claim C virus can be cured to the tune of 95%. Same is not true with the B. What is the problem?
Yeah, the basic problem is I didn't show you the life cycle of hepatitis C because of the lack of the time. This is the virus, which is an enveloped virus like COVID-19, SARS-CoV-2 virus. All these enveloped viruses, they have to be endocytized. Once it is endocytized, gets fused with lysosome and gets disintegrated into the cytoplasm. Hepatitis B, after disintegration into the cytoplasm, enters the nucleus and gets integrated with the host genome.
Oh.
So it forms a substance called covalently closed circular DNA or CCC DNA, which RNA virus like hepatitis C does not do. It does not enter the nucleus. That is the reason you are able to just kill it in the cytoplasm using the various methods of NS5A, NS3A, and NS5B inhibitors, unlike hepatitis B, which resides within the nucleus in the form of CCC DNA against which we do not have a drug, and it gets integrated into the host genome, which you cannot undo. That is the reason one persists and other can be taken care of.
Good. So this integration to the host genome is the key, which does not happen much in C virus, more in B virus. A question to Dr. LVK now. Would you recommend routine screening for hepatitis C virus in the master health checkup? What is the scenario in down south? What is in north? So Anil, both of you can take up. Routinely we should tell them, or only the high risk population?
I think at present we would recommend to do for the high risk patients. I don't think there is a routine indication to check hepatitis B and C in all the population.
Can I argue like that LVK, it hardly cost, even cheaper than ultrasound scan or cheaper than this. Suppose even if you detect 1.5%, that is our the incidence of hepatitis C, still you can save 1 lakh population you are going to do that. So when you think it is more prudent to do including hepatitis C in the master checkup, so what is your argument, LVK?
No, if you hepatitis C is now recommended to do only by the enzyme immunoassay. So I don't think we can ever do by the CAR test. But if at all you want to do an anti-HCV,
yeah, anti-HCV only I'm telling.
I think in a
costly
population, it is a high risk preparation is what has been now recommended.
So what is your take, Dr. Anil?
Yeah, see, I have a totally clear, drastic views. I think anything which is totally treatable and preventable should be screened. So I have a policy, any patient who comes to me, I always screen for 3 things: hepatitis B, C, and anti-HBs antibody. So this business of, people who develop complications of cirrhosis related to hepatitis C are totally asymptomatic. They may have received blood transfusion 20 years ago or before 1990 when they were during cesarean section or cardiac surgery or heart replacement, etc. And by the time they have cirrhosis and HCC, I'm sure CSC, you must be daily seeing patient with hepatitis B and C presenting for the first time with advanced HCC in which nothing can be done. So screening for hepatitis B and C is so safe, so simple, so cheap. I think at our level in gastroenterology practice, I always do it routinely. Because even if you pick up 1%, it is worth treating it. It's totally curable now.
I think I totally endorse the view of Dr. Anil Arora because I burned my fingers. Sometimes you see the evidence-based medicine, you need to really apply to the kind of practice we do and the kind of population we handle. So thinking that maybe LVK is right, there is no robust evidence from the evidence-based medicine to screen entire population. But what I'm asking a given patient, if you think so, that patient is bound to be positive or happen to be positive, then it's an enormous the impact will be then the treatment. So I will go by Dr. Anil Arora in this.
So can I add to that? If
Yeah.
you look at the goal of achieving an HCV eradication by 2030, do you know not 15% of our patients who have hepatitis C have been diagnosed to have hepatitis C? So I think it is a golden opportunity. If you come, somebody, as TSC has asked, if somebody has come to you for an executive checkup, it gives you an excellent golden opportunity to screen for it. Because 85% of the patients are still not diagnosed. How will we treat them? How will we cure them? And these are the people who may be the source of infection for others. Now you have a totally preventable disease. Please, if the patient comes to you, especially if the person can afford, never deny that chance.
Okay, quickly we'll ask the same question to doctors. Will you screen for hepatitis C virus? Same is to Dr. Baldas. Will you do hepatitis C virus in a master checkup or what
Yes,
is your
sir.
take?
I would
Akash
all,
and-
yeah. So I would agree with Dr. Arora. I would do it every single time. I'll give you one example, and why it is important to bring a test and bring all those people whom you test linked to the healthcare. I had a lady who died of HCC because of hepatitis C at the age of 55. She told me that she has donated blood 30 times in her life, and not once was she told that she had hepatitis C. So I'm sure the blood banks have tested for hepatitis C if she was diagnosed, but she was never notified. So I think it is important to test and ensure that they get linked to the care. I think that is where we have.
What is your take, Ubal? Ubal, you have to unmute and tell.
Like same thing, sir, because I'm fighting for including the anti-HCV for quite some time, last I think 7-8 years through Apollo management, because it was not there in the package. It is only hepatitis B is there, hepatitis C is not there. The problem they said was anti-HCV is supposed to be very expensive in those times. They never knew that the rate has come down. Even the management doesn't know that anti-HCVs can be quite cheaper. So
How
somehow
much it costs now in down south and north? Any idea?
In Delhi, Lal's lab, I think it is around 1,500 or so.
What about, I think it's much cheaper
Five-
now. Okay?
It's much cheaper.
550. 550.
550 only. I think.
As part of the national program now, it is free.
Yeah.
Okay, now so Upal, you will do anti-HCV, Akash will do that, I will do that, Anil will do that. Now LVK, you want to revise your opinion or you will hold on with that?
Yeah.
Maybe I'm not trying to corner, I just want to know your opinion because you have been living
Yeah,
with
certainly, we should screen for that. But I still say that.
I will tell you a small anecdote. A professor of medicine was being investigated every year on his birthday. Master health checkup was done, and a few years he has got it done. And I happened to see him for some weight loss, and then we investigated him. He had a huge hepatoma and anti-HCV IgM. I mean the C virus was positive. So he was asking me, and 3 months later he died. So I'm just putting in this forum. The reason is,
Yeah, anecdotal.
I think we need to do, and we should put our efforts to include it in the master checkup number 1. As Ubaldas rightly said, those days it was very costly affair. It was not available. Third generation, first generation, lot of pitfalls were there. Now it is easily available. It's hardly 550. So we should really tell our management to include this. This is the one important thing. And a
can
question to
I
Dr.
just
Akash.
repeat
Yes.
one of the points raised by Dr. Akash? That same thing was happening in Gangaram Hospital quite some time back when I joined Gangaram. That after screening for hepatitis B and C, the blood was discarded and the relatives were never informed. So I insisted that in case there is a positive diagnosis in private, at least inform the families, because if you do not inform, then they are potential source of infection to their spouses, to their children, to their family. And if left untreated, tomorrow you may have more problem. So as a routine, after I joined Gangaram, we have been informing the patients regularly. So if you pick them up at an early stage, I'm sure you will have much better treatment modalities and the outcome. Same thing should happen in all other centers. I'm sure there must be a lot of gastroenterologists.
Now we will have pointed question and brief answers because a lot of questions need to be taken. A pointed question to Dr. Akash from Professor Muhammad Habibur Rahman, Bangladesh. How do you still use Slimarin or we should use it in NASH? Is it justified? Number one. The number two question is how frequently are you using obitocolic acid and what is the subset of NASH patient do you use it? If so, what is the perfect dose and how long will take it to be done?
So the first question, we do not use Silimarin any longer for non-alcoholic steatohepatitis. There is no evidence to suggest that it is any long-term benefits. The second question about obeticholic acid, it is not yet approved for routine use, and therefore any use would be off-label use, and therefore it's not something which should be routinely prescribed. Even the US FDA has raised safety concerns that there's not enough data to prove the safety because it does increase the LDL. So I think we have to be very wary before we prescribe these drugs. If at all we prescribe these drugs, they would be for long term for sure. So you have to be extra careful. So right patient, right indication, maybe, but definitely after a lot of thought only.
Your take on soraglitazar, which has got the approval of the DGCA?
So I think we have data that it will improve the liver fat and it will improve the liver enzymes. We still don't have the paired biopsy data to show that there will be any improvement in liver fibrosis. So I think yes, to improve liver fat and enzymes, we may use it, but we don't. The real need is for those patients who have significant fibrosis in the liver, and that is where we don't have evidence that this drug works.
Okay, to all the panelists, yes or no? Vitamin E in NASH, will you prescribe or not? Starting
Yes.
from Ubaldas.
Yes.
Yes. And we saw yes means why? How long?
How long? It's very difficult, but I'm using it for quite a number of patients, and I used to follow with the FibroScan every 6 months.
Okay, you found it useful from your side.
Yeah.
And Dr. LVK?
If there is steatohepatitis, I use it.
Not simple ultrasound, they say LFT normal, you don't use it. So ultrasound shows some kind of fatty liver and LFT is deranged, then use vitamin E. How long LVK do you use?
I've used it for 1 year.
1 year. You are not worried about side effects of vitamin E?
I've not used it more than a year. And elderly, I'm very cautious about using them in elderly patients.
Cautious in?
Elderly patients like men.
Elderly patients.
Because there are some incidents of prostatitis.
And you would take Anil and Akash, vitamin E.
Problem is that I've never been convinced of its utility in NASH. How long would you give it? Why would you stop it in a disease which is going to lifelong? Why it's going to last lifelong? Then how would you stop it after 6 months? What does it do? The only reason I put it in use is two field. One is that you have charged the patient your face, you have nothing else to give. That is the reason you give vitamin E. That is the first reason. And the second reason is it is known to cause decreased inflammation. Just to jack up your own efforts and give confidence to the patient, because they have come to you for abnormal enzymes. So if you're tied over the crisis and help them go on to the lifestyle measures, I use it as a bridge, but not as a therapy for treatment of NASH.
This is slightly better than placebo, but not as innocuous as placebo. Because and why we stopped it? Because of side effects, and we know that it is not been very useful all the time. So we start.
The dose recommended is 800 international units per day. That is increase all-time cause mortality, increase hemorrhagic strokes, increase CA prostate, and what happens after 6 months. So just use it to give confidence to the patient that their enzymes are settling, number one. Number two, help them tide over the time when they're able to get on to the lifestyle measures, as Akash said, that is the most definitive therapy.
What about Akash?
So
Vitamin E.
so for only for patients who have steatohepatitis and not just patients with fatty liver, not more than 2 years for sure, simply because of the increased risk of hemorrhagic strokes and the increased risk of bladder cancer. And like Dr. Arora said, use it as a bridge till the lifestyle modifications happen and take the center stage.
Okay, now the same is what the take from the panel is about ursodeoxycholic acid. Many people use it. Same thing Anil said, okay, there's nothing else to do that. It controls the is one of the anti-inflammatory agent for to control the necrosis or anything, or bring down the liver enzymes. What is your take in NASH?
I don't routinely.
We don't really use ursodeoxy.
LVK, there is no indication to use, no?
Yeah. Okay. But at least initially, I think there was a lot of people we were using ursodeoxycholic acid. I think you can ask Dr. SP Singh to come and he has got some data on that. But at this moment, I don't think there's any role for ursodeoxycholic acid.
What about Akash?
No, sir, I don't use.
No, you don't use it. Upal?
I don't use it.
You don't use it. Anil, you don't use it. So simple. So we don't use ursodeoxycholic acid.
But if you look at the prescription of 100 hepatologists and physicians, 90 will be using it in their practice.
That is the reason why I'm asking here. So we'll at least we can appeal, or we can tell them that ursodeoxycholic acid, apart from managing liver function and little bit alteration, there is no real thing happening to come out of this NASH. So we may not use it. A pointed question from doctor from Malaysia is asking, genotype 3A to Dr. Anil and Dr. LVK. Genotype 3A with a child A cirrhosis, RNA load 3000 copies, LFT deranged. I'm audible? Do you do genetic testing routinely? And what should be the ideal treatment for this? I will repeat it. Genotype 3A with a child A cirrhosis, RNA load 3 lakhs copies, and LFT deranged.
Yeah, this is a typical setting of not an advanced liver disease. Genotype 3, which was supposed to be a friendly genotype, TSC, you will remember in our time, suddenly has taken a somersault and it is not going to be a villain now. But this will have an excellent response with a conventional combination of either 3 months of sofosbuvir and valpetasvir, or 3 months of sofosbuvir and ribavirin for another 3 months should be good enough to take care of it. There is going to be 95% response rate.
I think with the present pan-genotypic
genotype has no role, because the
current pan-genotypic response, sofosbuvir valpetasvir for 3 months should be able to give you a cure of 95 to 96% in a well-compensated. The only thing is we need to tell them is that he being a cirrhotic, we need to continue surveillance even after SVR for HCC in these patients.
What about genetic testing? N95, the genetic testing?
Genetic testing is not required. Genotype testing, you mean. Genotype testing is not required unless the patient has a relapse or is resistant to, or unless the patient has quasi-species and resistant virus. In general, with the current availability of drugs, which has a sofosbuvir as the main component, coupled with NS5A inhibitor like valpetasvir, you don't need anything else.
Do you believe?
You don't recommend, you mean resistance testing, sir?
No,
there's no recommendation for resistance testing now. Unless there is a relapse after an SVR or a reinfection after a long-term SVR. As sir said, there may be another species in the same subtype.
Yeah, he has written N90 resistant, RAS.
Yeah, resistant association strain. You see, that is, it doesn't matter if you are giving a combination. See, there is no routine recommendation of testing for RAS at the baseline level. So you give a good combination of sofosbuvir and valpatasvir for about period of 3 months in non-cirrhotic, for 6 months in cirrhotic, or a combination of sofosbuvir and ribavirin for 6 months in cirrhotic is good enough in 99% of the time. Only if there is a relapse or if the viral load does not come down. In fact, current recommendations are that you do not even need to do the genotype, and you do not need to do a viral load after 3 months. Do it
3 months.
as an SVR sample. That means once you finish your course, wait for 3 months and look for a sustained virological response sample.
Okay. Now we have
This is
8
a
more
simplified algorithm which was given by the ASLD. So you can just do a simplified algorithm.
Okay, we have 8 more minutes to wind up our session. And pointed question to Dr. Akash. Yes, adenosine methionine. Is it useful in NASH?
Answer is again no evidence to say that there is any long-term benefit with the use.
What are the medicine no evidence still be prescribed?
So I think I can give a full talk on this. I think there's a whole list, except for vitamin E, pioglitazones, the other zolindiones, and SGLT1 inhibitors, the GLUT2 inhibitors. I think, and now saroglitazar, the PPAR alpha gamma, and the obeticholic acid. I think other than these drugs, there is no evidence that any other drug works.
I request 1 point from each panel is what is an ideal exercise which will help in NASH? So we will start from LVK. 1 point. Need not everyone. That means not that everyone should.
Recommendation.
1 point. Everything put together, we have to do exercise.
The recommendation is to do at least 210 minutes of isotonic exercise per week, and then at least you do I recommend at least 60 minutes walking, number 1.
60
They can
minutes
go for
you recommend
60
every
minutes
day.
every day,
The whole
and sometimes
audience.
isometric exercise twice a week. The other thing we do is, now that we have a bariatric surgery department, there is a bariatric coordinator. We send them to them, and then they work out the exercise plan, they give the diet, and it seems to be helping these patients.
I will take up from you 60 minutes walking. Okay. What is
That's what
isometric exercise for the benefit of the audience?
Because it has been shown in the NASH that your mortality could be due to a stroke or a cardiac, and at least 40 minutes of this walking will help you to reduce your neurological or cardiac morbidity or mortality by 30%.
So I would advise
I do recommend
30 minutes walking, you're telling.
60 minutes.
Then Dr. Rubal, unmute.
Sir, exercise, I do CrossFit, but I am off late. I lost weight about 13 kg in the corona period due to intermittent fasting. So I believe in that intermittent fasting. So rather than exercise,
One of the few people who have lost weight in corona time.
Maybe because they don't have enough food, because they have to cook ourselves.
Many people have come to our hospital, they have put on weight. Actually, I will send them to you. So, okay.
So I think rather than workout, I think the intermittent fasting is a major.
So more than exercise, intermittent fasting, you feel?
Yes.
Okay, Anilji.
Yeah, I think I'll refer to you our recent, webinar on pathogenesis of obesity that had clear answers. They're more important than exercise. There is something called NEAT, non-exercise energy thermogenesis.
Exactly, I wanted to tell this because I attended your webinar. I was impressed. Exercise reduces only 5% of your weight.
Absolutely. And doing exercise requires commitment. During exercise requires you have to be out of the house, or you may have to spend extra time. But if you look at something called NEAT, not the usual NEAT for MBBS entrance, but this is a different NEAT, non-energy exercise expenditure. So what it means is that you do keep doing the household work rather than keep sitting the whole day. If you are examining the patient, repeatedly go out to the desk, examine the patient, come back, go to the bathroom, change your, do the gardening, do the household cleaning, just keep going around your garden quickly. And if you keep just doing the routine day-to-day activities, that makes you lose 30% of the energy expenditure. Out of the 100% energy expenditure which you do, 60% is done by the pumping of the heart and ATP synthesis, including the maintaining.
I have a problem here, Dr. Anil. Most of the women, when they come for consultation for obesity, they said, I'm a homemaker, I do all kind of work at home, and I don't lose weight. So what is the answer from your this one?
Ask them how many maids do they have at home. That is the
No,
answer.
there's no maid. They say I even checked it sometime. No maid.
So
So
this is
this concept, I really I don't know how to. Everyone says I'm cooking, I'm washing, I'm doing the little bit of gardening. So if you tell them more than exercise, non-neat, you said no. How much it is really important, going to have an impact among the homeworkers? Most of them are obese.
see
So I
that
have
day
my own.
in the pathogenetic processes, this is one of the components which can be easily handled, which most of us tend to
Okay,
under.
I think one thing I agree with you. While watching a TV, you can keep moving your legs, you can keep moving your fingers, and while watching your talking over phone, you can always keep moving and talking. All these things will help you a little bit. What is your concept about Akash? Exercise or neat?
No, I think it has to be individualized. I can't have the same regimen for a 70-year-old lady with NASH and a 25-year-old boy with this thing. So I think that it has to be a combination of isometric and isotonic exercises wherever possible, especially strengthening of the core muscles of the body and individualizing according to the patient's need. So I think that will
I
be my
think that is
answer.
a fantastic. I think all of you brought out very nice intermittent fasting. Number one, 30 to 60 minutes of walking, isometric exercise, isotonic exercise, and
Neat.
Dr. Anil
Neat.
said meat is very important now, and but Akash said tailor made to the patient. How much is BMI? What kind of work? Sedentary worker or laborer, and all these things very important. Some people say I do only yoga, I don't lose weight. Some people say I do exercise, but I keep eating more. They don't lose exercise. They don't lose weight. I think we need to analyze them, and we doctors may not have much time to do that. So we should refer it to, as you said, in a bariatric department. There is a counselor will be there, and he will be able to counsel better. Now, what is a lean NASH, and what is the thing about lean NASH, Dr. Akash?
Yeah, so there are people who have a near normal BMI or slightly abnormal BMI, and they would still have significant steatohepatitis in the liver. This is basically because of the predisposition of these people.
Insulin resistant.
It's very common and first reported from India, especially from Bengal and Orissa. Very, very common over there. And I think the other thing which we have now of late identified is that there is a genetic predisposition to this as well. And these are the people who have more outcomes related to the liver than because of extrahepatic diseases. Unlike the classical metabolic NASH, where the outcomes are more because of the extrahepatic disorders.
Even in lean NASH, there is an element of insulin resistance which drives the NASH.
So yes, there is a subtype who will have insulin resistance, that they are the ones who have more visceral fat.
Visceral.
So even the lean NASH actually is of two subtypes.
Okay, now coming to the last question to Dr. Anil, what is role of a stem cell transplantation in chronic liver hepatitis C? You seems to be interested in stem cell. So how much it has really thrown light into this?
Yeah, you see, we did the first project in India to look at there was a concept that in patient with cirrhosis of the liver, bone marrow is hypoplastic or aplastic and it does not respond to stimuli by the GCSF. So we did the novel experiment. We did the GCSF stimulation of the bone marrow. We did the apheresis of the patients with chronic liver disease. We collected the sample from the apheresis and infused it into the right hepatic artery through the femoral puncture in 6 patients. And we could show the improvement in the liver function in 3 out of the 5 patients. That was the initial experiment. But then there are a lot of caveats in that. We do not know how many of the cells which you picked up from the bone marrow will ultimately home into the liver, how many will be shunted away, what will be the life of these cells into the hepatocyte. This is all the basic experiment. And the type of facilities you were giving initially to me, if you hand it over to me, I think we can do a wonderful work. So if you can fund the project of doing research on the basic
funding for stem cell, you are very confident, hopeful that is going to throw more light on this. Okay.
As of now, it is too nascent to put it into clinical practice.
Too nascent, and you should not tell them, because many people come and ask that, sir, I have a stem cell. you please put it in my liver and I will get cured and all. I think
that
this
is
type
just
of concept we have to really tell them it is in the experimental stage and we have not really come to the clinical utilization. I think we had a wonderful fourth webinar series on landmark publication. It's not a regular lecture. It is not a just a panel discussion or symposium. I must thank thank you, Anil and Akash, LVK and Baldas for a wonderful interaction. And I would like to have to request you to share your slides since we are going to incorporate in the book. And wonderful webinar. I think you got a lot of feedback. I don't think I'll be able to take all the questions now. And whatever basic burning questions we have already answered. And it's a time to say thank you from our organizing secretary, Dr. Raju Yogesh, and our sponsor, Mr. Jayaraj. Okay, Dr. Raju Yogesh.
Good evening, everybody. It is indeed my privilege and honor to propose a vote of thanks and conclude the proceedings of this inspiring webinar. I should start by thanking Dr. T.S. Chandrasekhar, the organizing chairman and anchor, who is the mastermind of this webinar series. Thanks to him, we've had such excellent speakers today, doyens in the field of gastroenterology and hepatology. Dr. Anil Arora, a big thank you to you for a truly outstanding lecture. It was inspiring to follow the step-by-step discovery of hepatitis C and the evolution in its treatment. My sincere thanks to Dr. Akash Shukla for an extraordinary presentation, a truly commendable effort, sir, in bringing out the landmark advances in NAFLD. We thank our learned moderators, Dr. L. Venkatakrishnan, Dr. Ubal Das, and Dr. S.P. Singh for their insightful comments and inputs. We were really honored to have you with us to share your thoughts and wisdom. I must thank my colleagues here at MedIndia Hospitals, Dr. Prasad, Dr. Gokul, and Dr. Satyamurthy for the valuable guidance and encouragement. I wish to thank our support team, Ms. Sasikala, Mr. Sasidaran, and Mr. Shiva for the impeccable arrangements and logistic support. We extend our heartfelt appreciation to our academic partners and sponsor, Microlabs, especially Mr. Jayaraj, Mr. Swakshar, and Mr. Padmanabhan for their excellent support. Of course, we extend our wholehearted gratitude to you, the delegates, for your lively participation. Hope you enjoyed the webinar as much as we did. We would be glad if you join us for the 5th in the landmark publication series, which is scheduled for the 21st of next month. Team MedIndia, we wish you good health and joy. Goodbye.
Thank you.
Now, may I call upon Mr. Jayaraj?
Sir, Mr. Jayaraj is not available now. He's gone somewhere.
Okay, Swashkar.
Yeah, sir. Yeah, would like to thank on behalf of Microlabs, all the panelists, the speakers, as well as the commenter, and also moderators for making this program very interesting one. And we look forward for many more landmark papers in coming days and months. Thank you once again to the panelists and also the viewers. Thank you so much.
So before winding up, I once again thank you all of you for this wonderful participation. And 5th, 6th, 7th, 8th webinar is going to be have an international webinar series. So don't miss it. We have who is who in gastroenterology from all over the world. And I must thank all the delegates who have registered and attended from Sri Lanka, Malaysia, and Bangladesh, and Nepal, and other from Gulf countries, and some from Australia also. And I'm very thankful for this. And you can watch this entire proceeding in the YouTube and subsequently from tomorrow onwards. So you will, even those who have missed it can see that in the YouTube. So thank you once again, Dr. Anil, Dr. Akash, Dr. LVK, and Dr. Baldas. Thank you very much.
Thank you, sir.
Enjoy your festive season. Thank you.
What about the funds which you are giving for research, Dr. TSC?
What is the fund?
What about the fund?
No, it depends on what kind of research. You have to put up the research project. Then I can organize some fund.
Unlimited.
That is what, that depends on what kind of research.